Peripheral arterial pseudoaneurysms typically present as an asymptomatic incidental finding, but can become symptomatic if there is compression of local structures, ischemia, thromboembolic event, or vascular rupture. Now to our case. Here we have a 67-year-old male with a history of paranoid schizophrenia who presented with chief complaint of right arm weakness. 6 months prior to presentation, the patient noticed a right axillary mass. Then 3 months later, he developed right arm weakness, numbness, and swelling. 3 months after that, he presented his PCP and at that time demonstrated a right axillary pulsatile palpable mass with thrill. Initial imaging modality pursued with CT with IV contrast seen here, which showed a gigantic right axillary mass. Ultrasound was then performed, which demonstrated an axillary artery pseudoaneurysm measuring 5.5 by 5.4 by 5.3 centimeters with turbulent biphasic to and fro flow and an eccentric peripheral thrombus. The patient was admitted to the hospital and went for a surgical repair, but decompensated with induction of anesthesia. Intraoperative TEE showed biventricular failure, perforation of the anterior mitral leaflet, and mitral and tricuspid valve regurgitation. Emergent left and right cardiac catheterization was performed, which demonstrated diminished cardiac output, elevated left and right ventricular pressures, and pulmonary hypertension. Biventricular impellers were placed, and the patient was transferred to the ICU. After 10 days of volume and hemodynamic optimization, the patient underwent axillary artery pseudoaneurysm exclusion and bypass, utilizing an autologous saphenous vein graft with the assistance of a highly skilled cardiac anesthesiologist. His postoperative course was uncomplicated, and at 2-year follow-up, the patient was without symptoms of heart failure with just medical management. The patient has persistent right arm weakness and numbness and contracture of his right hand. When pseudoaneurysm is suspected, diagnostic imaging should be pursued, but no clear gold standard has been established. Ultrasound is an attractive method as it is non-invasive, cheap, and does not require ionizing radiation or contrast. However, its effectiveness can be limited by anatomy and is operator dependent. CTA is also useful but requires IV contrast to help differentiate pseudoaneurysms from cysts. MRI is usually not the initial imaging modality of choice but can be useful as an adjunct to ultrasound or as an alternative to CTA in patients with contraindications to IV contrast. Conventional angiography is an effective although invasive modality for diagnosis. In terms of treatment, no standard indications for intervention for axillary artery pseudoaneurysms have been established. However, it is generally agreed upon that symptomatic and large pseudoaneurysms should be treated. Small pseudoaneurysms can thrombose spontaneously, and management with serial ultrasound-guided compression has been described. Endovascular and minimally invasive approaches such as percutaneous thrombin injection, embolization, and stents are evolving for use in stable patients with amenable anatomy, but thus far data is once again limited to case reports. Surgical repair is preferred for pseudoaneurysms that are ruptured, expanding, infected, or cause ischemic injury. If concurrent brachial plexus injury is suspected, open surgery is generally preferred over endovascular treatment, as after endovascular therapy, an organized hematoma can form within the pseudoaneurysm, which makes complete decompression of the brachial plexus difficult. With all this in mind, I concluded that ultrasound and CT imaging were useful modalities for diagnosis of this axillary pseudoaneurysm, and open surgical exploration was an effective therapy. Thank you much for your time and attention. I hope you enjoyed this case and learning about axillary artery pseudoaneurysms.